my name is Kelly English, and I'm from the Arthritis Patients Advisory Board from the Arthritis Research Canada. And I'm here today with Dr. Lauren King, co-investigator, and Dr. Tetyana Kendzerska.
Yes.
Did I get that right? From the University of Toronto. I'm going to start with Lauren. Lauren, can you tell me a little bit about yourself and how you're involved in the field of rheumatology?
Thanks, Kelly. I'm an internal medicine resident at University of Toronto, and I'll be starting in the rheumatology program in July. So
We like to hear that.
Yeah, I'm very excited to move on to my rheumatology subspecialty training. And I've been interested in osteoarthritis for quite a long time, and it was through my master's work and seeing patients with osteoarthritis and the gaps in care that they've been receiving. It really made me passionate to kind of pursue a research career in osteoarthritis, as well as being a clinician going through the rheumatology training program.
And Dr. Kendzerska?
I'm a postdoctoral fellow, and I'm part of the research osteoarthritis team at University of Toronto under supervision of Dr. Julian Cocker. And I'm doing studies based on clinical and health administrative data, and really interested in long-term consequences of chronic diseases, and specifically osteoarthritis. And I'm working with this team and with Dr. Julian Cocker for about 6 years now.
And what is the impact of hip and knee osteoarthritis? Either one of them. On diabetes, on cardiovascular, do we know
I can
anything?
start a little
That would
bit
be
more with
great.
research that we've done with our osteoarthritis research.
Perfect.
Yeah, because the key message that we want to bring actually from this session as well is that osteoarthritis is not just part of the aging process. Osteoarthritis is a really serious condition. And based on our studies, we can say that presence and burden of osteoarthritis is associated with diabetes development, as I presented this morning, also with cardiovascular diseases, and we are trying currently our papers under submission. We submitted a paper on association between osteoarthritis and cardiovascular conditions. So also Dr. Hawker, she did a lot of studies looking on diabetes complications in patients with osteoarthritis. And she found that the degree of functional limitations is associated with increased risk of developing diabetes complications.
I can understand that. Yeah, I really can understand that.
And probably Lauren can add
Well,
from.
just to summarize, we've known for a long time that osteoarthritis, especially hip and knee osteoarthritis, because those are the common weight-bearing joints that are affected, are associated with a lot of bad outcomes, right? People have a lot of pain, they stop walking, then they have difficulty with their activities of daily living, and this leads to lower quality of life. But what's interesting now, and what our research group, led by Dr. Hawker, is interested in, is expanding and being part of this emerging data set or research into the impact of hip and knee osteoarthritis on other chronic diseases. So not only is it bad for the quality of life, and it's chronic to be in pain all the time, but actually you're more likely to have premature death, develop diabetes complications, develop cardiovascular disease. So again, just to reiterate, it's a really serious condition.
It is. And
It
once
couldn't
you-
be ignored.
And after that, all that stress definitely develops into depression. I think a lot of the audience
Yes,
can.
yes.
You nailed that. Depression and sleep problems, they just amplify the pain and disability that people with osteoarthritis face.
Now, you made a very good comment, and I don't think a lot of people know this. I have rheumatoid arthritis, and when I first got it, people said, oh, my grandfather had a little bit of rheumatism, and yes, I know what you mean. But we tend to think as well that osteoarthritis is an older person's disease, and I know that that's not true. Is that your finding as well?
Yes, this is what I'm trying to say, is that even just saying from statistical point of view, when we are adjusting, when we are controlling for age, when we are controlling for body mass index, all these risk factors associated with diabetes, with cardiovascular conditions, we show that having osteoarthritis, having functional limitations, actually associated with development of those conditions. So we couldn't ignore this disease. We need to pay attention to this disease, and we need to know how to manage these patients. Because improvement in mobility may prevent diabetes development, may prevent cardiovascular events development, and also may improve your mood. impression of that.
And it is that vicious circle.
Yes,
it's
and
definitely, and
yes.
the lack of exercise from the pain and the
Yes, and
function
this is, yes, because
does
your
lead to
sedentary
diabetes.
behavior, yes, will lead you to diabetes. This is correct.
Now, for osteoarthritis, have you seen any underlying themes, let's say, that are coming out? Like, for example, with all the diseases this time, we're seeing a lot of exercise programs coming out, motivational, and of course with the inflammatory arthritis, there are more meds. Are you seeing changes in osteoarthritis to the message going out to the patients?
I think, we need to reinforce the treatments that we have right now because they're still being underutilized. We know that maintaining a healthy weight, treating pain, and staying active are all really important first-line therapies that people early in disease, they should receive these treatments to prevent, progression, difficulty walking, and then all those consequences we talked about. In the long term, we do need to develop some disease-modifying therapy, like you have in rheumatoid arthritis, to be able to stop the disease early. But we're a little ways away from that, but that's going to be a long-term goal.
And one of the things that I've heard and read over the time, and I know that in soccer, for example, they're starting to address, is the sports-related osteo. Now, is that any different than what you're talking about?
Well, we know that sports injuries are a big modifiable risk factor for, let's say, knee osteoarthritis. You had an ACL tear when you were skiing as an 18-year-old, and especially if you haven't had proper rehab afterwards, then you're more likely to develop osteoarthritis. So we may see earlier osteoarthritis in some of these people because they have this additional risk factor of joint injury.
And with the diabetes, and I can see where you're coming from, you've got less pain, whatever, and you're more pain and you're not exercising as much, you're more sedentary, probably eating a little bit more junk food for comfort and less stress. And I know that a take-home message for a lot of us, and it's rather annoying sometimes, is that obesity. Because if you get obese in this whole process, you might have been a runner before and in wonderful physical shape, but I know you can become overweight. Now, how many of these were overweight before and the osteo was caused by the...
Oh, by becoming overweight first and then developing osteoarthritis?
Or
it's the most important modifiable risk factor, so something that you can change. You can't change your age or your genetics, but your weight is something that maybe, for some people, maybe less control,
right.
Others maybe more, but it's something that's really important. Keeping a normal weight will reduce your risk of developing osteoarthritis and reduce your risk of progressing if you do have osteoarthritis.
But even if you were in really good shape and you were, at the beginning, you could still develop osteo, I guess is what I'm saying. The osteo was not caused because, totally
we're
because
just
of the
saying
weight.
about two things. We're just talking about primary prevention of osteoarthritis and then prevention of chronic disease development in those with osteoarthritis. And actually in our cohort, about 16,000 participants when we used to do our research, we don't have a lot of obese patients because this data was collected between 1996 and 1998. So it's probably about 20% obese. And still, even without obesity, you're still at risk for developing diabetes because of your osteoarthritis.
That's really good to know.
Yes.
So
this is
it takes away the stigma sometimes of somebody saying, well, you must have gotten the
it's
osteoarthritis because of,
So
takes away
this cohort is a little bit different cohort, and we're getting this from reviewers as a comment that it's cohort collected in 1996. It's somewhat senior cohort compared to current cohort, but still, even with in our cohort with less prevalence of obesity, we still found this relationship between presence of osteoarthritis and number of knee and hips involved, and development of diabetes and development of cardiovascular conditions.
This is huge.
Yes.
This is very huge. Nita, do we have any questions from the audience?
So for someone who is customary to the sedentary lifestyle, how can we get them up and moving? Like, what is the best approach to getting someone up and moving?
So our intervention there.
So we know that lots of different kinds of exercises can help people reduce their pain, keep them functioning, helping them improve their function. And so it comes down to preference and goals. So finding an activity that you like. If you don't like swimming, then, you know, let's not make you go to the swimming pool.
I agree, yeah.
You know, maybe you like going on a
Finding a
bicycle
warm
or
swimming
walking.
pool is help.
That's right.
That's absolutely.
And then what is the goal? What would you like to be doing? And if your goal is to go hiking in next summer, well then let's target our exercise towards that. And I think you can think of exercise as any kind of drug that you titrate up. So you can start at a really low level if you're accustomed to being very, very sedentary, then starting with 5 to 10 minutes a day. That's a very, very reasonable approach. And then based on how you're feeling, gradually increase. We know that even probably 10 to 15 minutes of exercise a day will be quite effective.
And Dr. Phelps was talking yesterday to me.
Yes.
And it was a great talk, yes. And he said only to increase by 10% a week, even for an athlete rehabbing, was 10%. And then you won't hurt yourself. That's a really good video to watch, by the way. It was very informative. And we know that exercise does bring down diabetes, does bring down
Mortality. Yes.
pain, it increases function. Yeah. Well, thank you. I've learned a lot here. And I'd just like to wrap it up by saying one of the things we know is that it's not just an old person's disease. It's not just the old wear and tear that they said. You don't have to worry about going upstairs. At one point they used to say if you had osteo, do not do stairs, save your joints. And very important for both the diabetes and the osteo is to break that cycle early. Keep your weight down, keep your exercise is what you're saying will also help. And early intervention, I imagine.
Mm-hmm.
You know,
A healthy diet.
Healthy diet.
Good sleep, less stress.
and hopefully in the future we will learn what some of these markers are for osteo, so that maybe we don't even have to go through this in future generations. It would be wonderful.
Yes.
Thank you so much for your research, and I look forward to hearing something about cardiovascular in the next few years
right.
too. So,
Thank you.
thank you.
Okay, thanks for having us.